announce our special guest speaker today, Dr. Paul Steinfield. I'm sorry, I'm getting texts. I apologize, guys. So Dr. Paul Steinfield is a board-certified orthopedic surgeon. He received his medical degree from Hahnemann University School of Medicine in Philadelphia. Dr. Steinfield completed an internship in surgery and a residency in orthopedic surgery at Montefiore Medical Center Hospital of Albert Einstein College of Medicine in Bronx, New York. He then completed a fellowship in hand surgery at Thomas Jefferson University Hospital here in Philadelphia, as well as a fellowship in sports medicine from Lankenau Hospital in Wynwood. Dr. Steinfield is a member of the American Academy of Orthopedic Surgeons and Pennsylvania Orthopedic Society. Aside from general orthopedics, Dr. Steinfield specializes in adult joint reconstruction and hand surgery at Nazareth Orthopedics. So without further ado, I'll hand it to you, Dr. Steinfield.
Thank you, Michelle. In this presentation, I'll discuss common musculoskeletal conditions that are seen every day by primary care physicians. These cases are all conditions that are referred to me by primary care doctors. I will not discuss fractures that usually present to the emergency department. I will discuss the diagnosis and management of these conditions, including surgical solutions. In my practice, I almost always will try non-operative measures before considering surgery. Because non-operative measures work so well in most cases, and most of these conditions, surgery is not often needed. These non-operative treatments that I'm going to discuss are easy to apply, and I will discuss simple injection techniques that can be used by any provider. So I'm going to start with the trigger finger. This is a very common condition. Almost everybody experiences some form of trigger finger at some time. Trigger finger may present as transient pain in the palm or over the palmar portion of the finger. Trigger finger may present with locking or catching of the finger or just with pain. Trigger finger is an inflammation of the tenosynovium. The tenosynovium is the filmy tissue that surrounds and moves with the flexor tendon. As the tenosynovium becomes inflamed, it and the tendon become swollen. The tendon sheath is the fibrous tissue that encloses the tendon. The tendon glides inside the tendon, inside a tunnel formed by the tendon sheath. The floor of the tunnel is bone, the phalanx, and the roof of the tunnel is the tendon sheath. The inflammation that occurs causes pain. The swelling causes clicking, catching, locking of the tendon inside the tendon sheath. So the trigger finger has nothing to do with guns. The trigger concept comes from the finger locking or catching or triggering. Symptoms are most severe in the morning. Trigger finger is the most common source of hand pain. The pain is usually localized to the distal palm where you see the arrow. You can palpate the swelling around the tendon in this area. When the tendon becomes severe, when the swelling becomes severe, the tendon can get stuck under a normal thickening of the tendon sheath called a pulley. This causes the finger to lock in flexion. The finger has a number of pulleys which keep the tendon close to the bone, and this allows for maximal efficiency and strength of the tendon. The tendon always gets caught at the first pulley, the A1 pulley. So trigger finger is a tunnel syndrome. Most of the tunnel syndromes that we see involve nerves. This is a tunnel syndrome that involves the flexor tendon. This is a classic locked finger, a classic trigger finger. If the swelling is less severe, the symptoms may just be pain, catching, or clicking with finger motion. But when the swelling is severe, the locking occurs. The ring finger is the most common digit involved. Because of their anatomy, some people are more prone to having multiple trigger fingers. Patients with inflammatory conditions such as rheumatoid arthritis are more prone to having multiple trigger fingers. My preference in treating the trigger finger is a cortisone injection. I use a half cc of Kenalog or Celestone or Depomedrol mixed with 4 cc's of saline in a 5 cc syringe with a 25 gauge short needle. So I feel for the tendon with my index finger as I flex and extend the patient's finger. I then mark the spot with an imprint of my pen tip after I've retracted the writing point. The needle is placed at a 45-degree angle just distal to the distal palmar crease and is inserted about 5 to 7 millimeters. As I inject, I feel with my index finger as the tendon sheath fills up with a solution. Once I know I'm in the sheath, I only inject about a cc of the solution. If I don't feel the bulging of the tendon sheath as the mixture is injected, I will redirect my needle. The arrow here, the red arrow, points to where I place my finger to feel for the tendon sheath as it's filling up as I inject. You want to avoid injecting the tendon itself. You're trying to inject the solution just inside the sheath, but not inside the tendon. You want to also avoid injecting the digital nerves and digital arteries. But if you feel for the tendon and mark it carefully, you're really not going to hit the adjacent nerve or artery. Again, to be precise with needle placement, I feel for the exact spot with my finger. I then take my pen with the writing point retracted and make an imprint in the skin. The imprint usually lasts for about 30 seconds, and this allows me time to thoroughly prep the skin with a cotton ball soaked in alcohol. This is the key to giving an injection. This is what sometimes allows me to give a painless injection. Ethyl chloride produces a localized anesthetic effect while being sprayed. I spray it while inserting the needle into the skin. Ethyl chloride used to be used to produce a gasoline additive. It's now also used as a refrigerant and as an aerosol spray propellant. So cortisone is actually a misnomer. The injection given is hydrocortisone, which is another name for cortisol. Hydrocortisone is a corticosteroid, and corticosteroids are a class of steroid hormones that are produced in the adrenal cortex. Corticosteroids are involved in a wide range of physiologic processes, including stress response, immune response, and regulation of inflammation. Many of the so-called cortisones that we use are synthetic corticosteroids. Cortisone, of course, is used to reduce inflammation. There are some adverse effects with cortisone, most importantly hyperglycemia, which can be rather severe. I've seen patients go up to 500 in their blood sugars after injecting just a half cc of cortisone. Another concern is an increased risk of infection, especially when used during or immediately after surgery. Cortisone can inhibit protein synthesis, so repeated trigger finger injections can lead to tendinosis, a breakdown of the tendon fibrils. Repeated cortisone injections can lead to tendon weakening and tendon rupture. This is especially true with injections into the Achilles tendon, the patellar tendon, or quadriceps tendon. And those injections really should not be done, especially in the elderly. Cortisone can cause cartilage damage if used too frequently. I usually will stop at 2 injections for trigger fingers and then offer a surgical solution. But for most patients, this is the cure for trigger finger. Finger splinting for trigger finger is a reasonable treatment option. I use it in certain situations, especially when the onset is within the past 4 weeks. Nighttime splinting is effective for those who wake up in the morning with a locked finger. It usually takes about 4 to 8 weeks to work. The splint works on the principle of resting an inflamed structure, and rest helps reduce inflammation. When locking and pain persist and simple measures don't work, I will do a trigger finger release. Here, a 2 centimeter transverse incision is made over the distal palmar crease to expose the flexor tendon sheath. The A1 pulley is identified and is cut longitudinally. And when this is done, it opens up this fibro-osseous tunnel and it frees up the tendon. The stenosis is then relieved, the catching and locking stops, and the pain usually goes away in about 4 weeks. And I would say that less than 1 in 10 cases of trigger finger require surgery. Moving on to the carpal tunnel syndrome, patients with carpal tunnel syndrome present with complaints of numbness and tingling, pins and needles. Patients frequently complain that this wakes them from sleep at night. They will say that they shake their hands for relief of symptoms. Patients will tell you that they have increased symptoms while driving and while holding a phone. They'll also tell you they have increased symptoms, increased numbness and tingling while holding a newspaper, magazine, or book. Patients will tell you that they get relief of symptoms when they drop their hands by their side. Some patients complain additionally of pain that radiates up the arm along the course of the nerve. Many patients will tell you that the symptoms become severe when they're riding a bike or playing tennis or golf. It's important to distinguish between pins and needles and numbness, which can be tricky sometimes. So numbness, as opposed to pins and needles, occurs when there's a nerve injury or when there's cervical radiculopathy. So looking at the anatomy, the median nerve comes off the lateral and medial cords of the brachial plexus and has contributions from nerve roots C5 through T1. The median nerve, along with the ulnar nerve, innervates the flexors of the wrists and fingers. And the median nerve specifically innervates most of the muscles of the thenar eminence, that is the thumb, and provides sensation to the index, middle, and ring finger and the thumb. So the carpal tunnel is another fibroosseous structure, just like the fibroosseous tunnel we saw in the trigger finger. The floor of the tunnel is the carpal bones, and the roof of the tunnel is the transverse carpal ligament. Through the carpal tunnel pass 9 flexor tendons, which bend the fingers and the wrist, plus the median nerve, which makes for a very tight space. It doesn't take much for the nerve to get pinched or compressed inside this tunnel. Inflammation of the tenosynovium and swelling of the flexor tendons is the usual source of increased pressure inside the tunnel, and this is why the cortisone injection can be so helpful. Going back to our earliest days of training, you will remember, I hope, that the first mode of physical examination is observation. In many fields of medicine, one look can give you the diagnosis right away. This picture demonstrates thenar muscle atrophy. This is more commonly seen in the elderly, and this is a case of severe atrophy, and this is clear evidence of carpal tunnel syndrome. You really don't need any more information or any investigative studies to make the diagnosis once you see this. You can look at the hand and without any question say to the patient, you have carpal tunnel syndrome, but of course most cases are not that simple. In less obvious cases, you want to do some palpating, some percussing. Tinel sign is positive. This is something you'll see dictated in all physical examinations for nerve compression syndromes. Tinel was a French neurologist who wrote about his findings in 1915. He found that percussing or tapping over an irritated or compressed injured nerve produced paresthesias distally along the distribution of the sensory fibers of that nerve. Often these patients have relatively normal sensation of the fingers when tested for light touch. I will always examine for carpal tunnel syndrome by compressing the carpal tunnel with my fingers and then flexing the wrist for 30 seconds. If the patient has carpal tunnel syndrome, this will produce paresthesias in the fingers. So for treatment, this is always the first step. Most patients who come to see me for carpal tunnel syndrome have already spoken with their PCPs and already have picked up a splint. The splint is a nighttime splint, and it does help with nighttime wake-ups from the pins and needles. This is the one thing that often brings patients to see me, the fact that they can't get through a night without waking up several times from pins and needles. I usually tell patients to wear the splint 12 hours every night. And if they have symptoms while working, it does make sense to use a splint during the daytime. A surprising number of patients who have early carpal tunnel syndrome respond very nicely to splinting. And for some, the symptoms resolve completely just with splinting. The splint works by holding the wrist in this neutral position. Most of the time, people sleep with their wrists in extended or flexed position, which reduces the space inside the tunnel and increases the pressure on the nerve. A very effective way to treat carpal tunnel syndrome is with a cortisone injection. I do this with 1/2 cc of cortisone mixed with 4 cc's of saline. I don't use lidocaine because it leaves them with numbness of the fingers for several hours. But I will use a short 25 gauge needle, which is a 5/8 inch long needle. The needle is placed just ulnar to the Palmaris Longus tendon. The Palmaris Longus tendon is a very easy to find tendon. You can find your own Palmaris Longus tendon by putting your thumb against your 5th finger and then forcefully flexing your wrist against resistance, and then the Palmaris Longus will stand out. So again, the needles pass 5 to 8 millimeters into the skin, and just a cc or 2 of the solution is all that's needed. If the patient experiences any sudden severe pain or paresthesias, you need to pull back a few millimeters. It means your needle is too close to the nerve. And some hand surgeons prefer to have this done under ultrasound to make sure the nerve doesn't get stuck with a needle. You don't want to inject cortisone into the nerve. This is a potential serious complication of injecting the carpal tunnel. But if you go slow and listen to your patient, you'll be fine. So again, about the Palmaris Longus, this is how you demonstrate the presence of the Palmaris Longus. About 15% of people do not have a Palmaris Longus, but the Palmaris Longus is a very useful tendon in tendon graft surgery because it's easy to find, it's easy to harvest, and really leaves no functional deficit. The Palmaris Longus is considered a vestigial structure and really has no clear-cut discernible function. So again, placing your needle ulnar to the structure will keep you out of trouble. Carpal tunnel injections early on in the case of the condition can actually lead to complete resolution of symptoms. More often, the injections provide for temporary relief, but the injections obviously can be very helpful during pregnancy when there is increased incidence of the condition. The injections can be very helpful in the elderly where the results of surgery are less certain. When a patient responds well to a carpal tunnel injection, this confirms the diagnosis and also provides a prognosis for the success of the surgery. If the patient doesn't get much relief from an injection, there's a good chance that surgery will not be successful. So when simple measures fail and symptoms are severe, carpal tunnel surgery is indicated. In this procedure, the transverse carpal ligament, that is the roof of the tunnel, is cut. When this ligament is cut, the tunnel opens up and the pressure is taken off the nerve, and the nerve is able to recover from the compression. This procedure can be done either open or endoscopically, and with the endoscopic technique, an incision is made at the wrist crease, and then an instrument is placed into the carpal tunnel under the transverse carpal ligament. Then a cutting blade is inserted and the ligament is cut from its underside under direct visualization with a camera that's inside the wrist. With the open technique, the palmar surface of the ligament is visualized and cut. The endoscopic technique results in a faster recovery. The open procedure is through an incision in the palm, which often can be a source of postoperative pain. The open procedure tends to cause pain that lasts a few weeks longer than the endoscopic procedure. So the first carpal tunnel release was performed in 1895. We're not sure exactly how it was done, but at that time in history, doctors probably did a lot more harm than good. About 5 to 8% of surgically treated cases can recur. Prolonged carpal tunnel syndrome can lead to significant loss of pinch strength due to atrophy of the thenar musculature. And there are several reasons why surgery sometimes is not effective. The most important is the wrong diagnosis, but also important is an incomplete release. And then diabetics who have diabetic neuropathy often have problems getting a great result from surgery as their sensory function is somewhat compromised by their disease. And then chronic cases in the elderly often don't do as well. In these cases, the nerve develops irreversible changes. Dequervain Tenosynovitis is a common risk condition. It's a tenosynovitis. It affects the filmy tissue around the tendon. It affects the tendons of the first dorsal extensor compartment, the extensor pollicis brevis, and the abductor pollicis longus. These tendons abduct and extend the thumb. This is another tunnel syndrome where the tendons pass through a fibroosseous tunnel. And again, the floor of the tunnel is bone, and the roof of the tunnel is the extensor retinaculum. The extensor retinaculum is a thickening of the fascia that holds the extensor tendons of the fingers and wrist in place. This condition is more common in females and is more common during pregnancy. Patients complain of radial-sided wrist pain. They have pain with thumb motion. They may note swelling in this region. They have difficulty with pinching. This photo demonstrates the so-called Finkelstein's test. In this test, you ask the patient to grab their thumb, and then you passively ulnarly deviate the wrist. This produces pain. It puts maximum tension on these tendons, and the patients often shout with pain. The pain in Dequervain Tenosynovitis is well localized to the bony prominence of the radial styloid. Sometimes there's swelling in this region. Sometimes there may be a little lump that feels like a bone prominence, which is actually a thickening of the retinaculum. Sometimes there's a cyst in this region from the degeneration of the retinaculum. Treatment starts with a thumb spica splint. This is different than the carpal tunnel splint because this splint locks up the thumb. And by locking up a thumb, this immobilizes the two tendons that are the culprits. This is best worn around the clock. And if this doesn't do the job, then the mighty cortisone injection is introduced. This is done just like the other injections with a half cc of cortisone. Any brand works equally well. I use a 25 gauge short needle. I use 4 cc's of lidocaine and a 5 cc syringe. The needle's placed at a 45-degree angle right over the radial styloid, right over the point of maximal tenderness, right over the bony prominence of the radius. It's advanced about 5 to 8 millimeters. And here, as you inject, you can use your other finger to feel the sheath filling with fluid, just like you do when you're injecting a trigger finger. You tell your patients afterwards to apply ice the next night and the next day. I will give most patients 2 injections before considering surgery. When all else fails, a tendon release is the treatment of choice. This involves making a 2-centimeter transverse incision right over the radial styloid. This picture shows a much larger incision. This incision is actually too big for this problem, but the incision here does demonstrate the 2 tendons as they cross the radial styloid. These tendons have already been released. They've been freed from their stenotic tunnel. But the surgeon, in this case of Dequervain Tenosynovitis, must be on the lookout for hidden tendons inside hidden tunnels inside the main tunnel. It's the old tunnel within the tunnel trick. The hidden tunnel is easy to miss as it is intimately attached to the bone, and this hidden tunnel has an extra tendon slip that must be released. If the additional tendon inside the hidden tunnel is missed, the symptoms may persist. And another danger during surgery is cutting the fine radial sensory nerve branches. The radial sensory nerve arborizes in this region, and its fine branches, which are tiny, can be injured by retractors or by a careless use of the scalpel. But the only time the surgery really doesn't work is when the diagnosis is wrong. Like in all fields of medicine, upon presentation of signs and symptoms, there always is a differential diagnosis. When we talk about radial and ulnar sides of the wrist, the radial side is where the radius is, where the thumb is. The ulnar side is where the 5th finger is, where the ulna is. Pain localized to the radial wrist, where you find point tenderness in Dequervains, can be coming from other sources. The most common is arthritis of the joint between the thumb metacarpal and the carpal bone. It can look just like Dequervains. When the history is one of a fall and an outstretched hand, a scaphoid fracture has to be ruled out. And the 4th diagnosis in the differential is what I call the great imposter, cervical radiculopathy. So cervical radiculopathy always fakes out doctors, especially orthopedic surgeons and shoulder surgeons. If there is pain anywhere in the upper extremity, it could be caused by cervical radiculopathy. More about that later. So thumb carp metacarpal arthritis is fairly common and can present much like Dequervains. The red arrow shows the arthritic joint, the metacarpal on top, the trapezium on the bottom. The yellow arrow points to the radial styloid, the point of maximal tenderness in Dequervains, and S is the scaphoid. Very often the diagnosis can be made through careful and precise palpation. The area of point tenderness for these 3 conditions are only about 1 centimeter apart. The space between the 2 arrows is called the radial snuff box. The radial snuff box is the home of the scaphoid. Point tenderness in this spot is indicative of either a scaphoid fracture or arthritis between the scaphoid and trapezium. So the radial snuff box, or the anatomic snuff box, is the little depression at the base of the thumb. This void is formed by the borders of the extensor tendons of the thumb. If you extend your thumb, you'll see this little hollow. Back in the day when gentlemen used to use snuff, which is a finely ground tobacco, the finer fellows would open up their little pocket canister and tap the powder into this anatomic snuff box and then snort to get their fix. At least that's what they say. I attended Honda Medical School in the 70s, and an emphasis of their curriculum was early exposure to clinical medicine. The program early in the first year exposed us to the art form of taking a good history and a good physical. And this was our Bible, DeGowan and DeGowan. It's been around for close to 60 years. It's now in its 11th edition. And in orthopedics, the physical examination and history remain key to making the correct diagnosis. I think it's clear to everybody who practices medicine that these days there is much too much reliance on imaging studies. Patients come to the ER and routinely get MRI studies and CT scans that are completely and totally unnecessary. A careful physical examination will most often give you the information you need. In orthopedics and in treating patients with musculoskeletal conditions, physical examination is the key to diagnosis and treatment. The thumb CMC joint is one of 5 CMC joints of the hand. It's the only CMC joint that becomes arthritic. It becomes painful, and that's because it's a very mobile joint. The other CMC joints are minimally mobile, and it's rare for the other joints of the thumb to be a source of pain. Arthritis of the thumb metacarpal phalangeal joint, the MCP joint, is not common, and arthritis of the joint just distal to that, the interphalangeal joint, is even less common. The CMC joint breaks down because it's a saddle joint with a high degree of motion in all planes. The CMC joint of the thumb has 2 relatively flat adjacent cartilage surfaces, and it's this combination that produces significant shearing forces on the cartilage. So when you pinch, the thumb applies force equal to the forces applied by the opposing 2 or 3 fingers. So significant force is always transmitted through the thumb to the thumb CMC joint. And that, coupled with the rather flat surface anatomy of the bone ends, leads to high shear forces, and cartilage does not do well with high shear forces. It breaks down. So the x-ray on the left shows a normal CMC joint in a young patient. The x-ray on the right shows a severely arthritic CMC joint. This x-ray shows the characteristic findings of severe osteoarthritis. You see severe joint space narrowing with loss of joint space. You see an increase in bone density, where the bone is whiter due to the increased irregular stresses on the bone. You see osteophytes or bone spurs at the periphery of the bone ends. Osteophytes seem to grow to reduce joint motion. And you see subluxation of the joint. The thumb metacarpal is shifted radially, and this results in a bump at the base of the thumb when you look at the hand. CMC joint arthritis is also called basal joint arthritis, and patients present with radial-sided wrist pain and thumb pain. They complain of difficulty turning keys, opening jars, opening bottles. They have difficulty using tools. It's often seen in both hands. Patients complain of dropping things due to weakness caused by the pain, and they often get relief with anti-inflammatory medications. On examination, there is point tenderness over the joint, and if you palpate carefully, you can feel the slight indent between the 2 bones, between the metacarpal, the thumb metacarpal, and the trapezium. This spot is just distal to the radial snuff box. When you grab the thumb metacarpal and grind it against the trapezium, this elicits pain in the basal joint arthritis situation. And then when you push on the thumb metacarpal in an ulnar direction, this is painful. X-rays will then confirm the diagnosis. And just like with the other conditions of radial-sided wrist pain, a thumb spica splint, which locks up the thumb, is the first step in treatment. I treat this condition with a cortisone injection. The joint can be palpated with your index finger. You feel for the indent under the skin where the 2 bones meet. Same recipe, 25 gauge short needle, 1/2 cc of cortisone mixed with 4 cc's of 1% lidocaine, then add a pinch of ethyl chloride spray to dull the needle stick. All you really need is a 1/2 cc of the solution inside the joint, and you'll know you're inside the joint because you'll start to see the metacarpal move a little bit as the joint fills up with fluid. There are dozens of surgical treatment options for this condition. My preference is a very simple resection arthroplasty. In this procedure, I use a 4-centimeter incision. It's made right over the radial aspect of the joint. The trapezium is then removed or resected. I then use the joint capsule that remains to stabilize the metacarpal base with a drill hole and sutures. Other surgeons will split a wrist flexor tendon longitudinally. They'll split it in half, roll it up into an anchovy, and fill the space with a procedure they call an anchovy procedure. But you really don't have to fill the void created by removing the bone. Things fibrose over time, and the thumb stabilizes. And again, it does make sense to do something, though, to stabilize the base of the thumb. I use the drill hole and sutures. And then there are some surgeons who prefer a fancier approach to this condition and choose to replace the joint with a titanium implant. This one looks like an upside down hip replacement with the ball and socket. I think this is overkill. This is technology trumping reason. These implants are associated with loosening and dislocation of the ball and the socket. I have found that in most cases, the simplest approach is the best approach, and resection arthroplasties have stood the test of time. And resection arthroplasties provide long-lasting relief. Patients have excellent function, have no strength or motion deficits. Ganglion cyst is a rather common presentation to the PCP's office. These cysts are usually painless and they're not related to an injury. They often just pop up and quickly grow to these sizes. Ganglion cysts are filled with concentrated joint fluid that becomes gelatinous. They can go away spontaneously, but it can take months for this to happen. They can be aspirated or they can be injected with cortisone. If aspirated, I use an 18-gauge needle, and that's required because the fluid is so viscous. I'll usually inject 2 cc's of lidocaine with a 25-gauge needle before using a large bore 18-gauge needle to aspirate. The dorsal wrist ganglion is easy to aspirate, but this picture shows the volar wrist ganglion, and it's not so easy to aspirate because it's just right next to the radial artery, and there is definitely a risk of hitting the radial artery with a needle as you're trying to aspirate the ganglion. The volar wrist ganglion is best aspirated or injected with the aid of ultrasound so you can watch the artery and the ganglion cyst as your needle enters the cyst. Aspiration or cortisone injection of the ganglion can provide a cure, but more often these things do recur. After injections, recurrence rate is about 60%. So this is an intraoperative view of the ganglion as it's being excised. I will usually try at least 1 aspiration or injection before I recommend surgery. I tell the patient that surgery is never needed. Surgery is not needed. It's just a matter of, does the patient want this to go away now? And if they want this to go away now, surgery is the treatment of choice. The key to surgery is to remove the part of the joint capsule where the stalk of the ganglion takes origin. There's often an intra-articular duct where the stalk meets the joint capsule, and this acts as a one-way valve that allows the fluid to fill the ganglion cyst with joint fluid. Recurrence rate after excision is 15%. These things still recur, but at 15%. There are 2 other common locations of ganglion cysts in the hand, and these are also rather common. One is the flexor tendon sheath ganglion, which is pictured on the left. These cysts arise from the tendon sheath that surrounds the flexor tendons. The other is a cyst located over the dorsal surface of the distal interphalangeal joint of the finger. This is usually associated with arthritis of this joint. So arthritis of these distal finger joints is very common with age. With age, osteophytes associated with the arthritis produce lumps over these joints. Historically, these were referred to as Heberden's nodes. Usually this arthritis is asymptomatic. Rarely this arthritis leads to the production of these ganglia. We also call these ganglia mucus cysts. Just a quick refresher on some terminology. Distal, of course, refers to that part which is further away from the body. Proximal refers to that which is closer. Dorsal refers to the back or posterior side. Anterior or ventral, or in the hand, palmar, refers to what's in front. When thinking of the hand, what's in front is based upon the anatomic position where the palm faces front. So this picture doesn't show the anatomic position of the hand as the palms are not facing front. The ganglia of the flexor tendon sheath and of the distal interphalangeal joint are really too small to aspirate. They're tiny, but they can be injected with cortisone, which can be helpful. These ganglia are often painless. The flexor tendon sheath ganglia, which is pictured here, often produces a functional problem, and patients will tell you that when they go to grasp things, it feels like there's a little marble in their hand. With the mucus cyst, patients will often try to drain these with a pin, and they end up infecting their joints. Sometimes the mucus cyst will get large enough to cause extreme thinning of the skin and will rupture spontaneously, which can lead to a joint infection as well. Both of these cysts, if they last more than 2 months, usually end up getting excised, and yet they can eventually go away without treatment. Moving up the arm to the elbow, a rather common condition the PCP will see in the office is lateral epicondylitis, also called tennis elbow. This is a condition that can be caused by overuse in sports. This can be caused by a change in activity or a change in arm positioning while working. The condition can come on as a consequence of a simple elbow contusion, a bump or a bruise. It's often most frequently comes on with no clear-cut cause. Patients will complain of constant low-grade pain that becomes more severe with activity. They point to the lateral epicondyle of the elbow as the site of their most significant discomfort. The condition specifically involves the extensor carpi radialis brevis origin. The origin of a muscle is the site that doesn't move during muscle contracture, and the insertion site is where the muscle or tendon moves. An MRI study will show an increased signal in this muscle where it attaches to the lateral epicondyle. The MRI read will often be a partial tear of the ECRB. The lateral epicondyle is on the outer aspect of the elbow, the lateral side. Medial is a term used for closer to the body or center of the body. There is hypovascularity of the muscle in this area, with granulation tissue often found underneath the muscle. When you examine these patients, there is point tenderness over the lateral epicondyle. When the patient tries to extend their wrist against resistance, they have pain localized to the epicondyle. And when the patient tries to extend their middle finger against resistance, they have pain that's localized to that spot. And when they try to supinate their forearm against resistance, that is, when they try to rotate their forearm so that their palm is facing up, they have pain in the region of the lateral epicondyle. Very often people play tennis and use their backhand quite a bit, will experience episodes of lateral epicondylitis. For these cases, there are tears of the extensor brevis muscle. For this reason, treatment has to include a change in their playing style. Rest is usually not the answer. Physical therapy is the most appropriate treatment for this condition. Therapy is used to stretch and strengthen the extensor muscles of the forearm. This is often combined with the use of what are called passive modalities that include things like therapeutic ultrasound, electrical stimulation, and even shockwave therapy. I will often prescribe an elbow strap, which goes on the forearm just below the epicondyle. And this seems to relieve tension on the attachment site of the extensor muscles at the elbow. A wrist splint can also be very effective by reducing the work of the extensor muscles. It's important when treating many of these conditions not to be an injection fiend. There is a limit to how often cortisone is the answer, and that is certainly the case in this situation. For the sports-minded or fitness-focused patients, it may be best to avoid cortisone altogether. But as a one-time treatment for the right patient, it is sometimes reasonable to inject cortisone into the point of maximal tenderness. And again, there's more to injections than just cortisone. Platelet-rich plasma has been used over the past 2 decades to treat certain tendinopathies and all kinds of other things. Evidence for its benefit is mixed. It has been investigated for things like oral surgery, plastic surgery, hair regrowth, facial rejuvenation, and in the treatment of osteoarthritis. The theory is that the growth factors produced and found in platelets are able to enhance healing and tissue repair. And these growth factors stimulate and increase number of reparative cells in the body. So the use of PRP is promising in the treatment of certain conditions: lateral epicondylitis of the elbow, patellar tendonitis of the knee, quadriceps tendonitis of the knee, and severe ankle ligament tears. There are conflicting reports about its efficacy in rotator cuff tears and injuries of the Achilles tendon. One of the problems with using PRP is that insurers do not pay for the procedure. Patients have to pay out of pocket. Average costs are around $1,000. PRP has been used widely in sports, although the data is still unclear. And it's because there are no adverse effects or reactions to injecting one's own plasma that there is no downside to using it. In acute injuries, there is just not enough data to know if it is in fact speeding up the healing process. Much of the enthusiasm about PRP come from anecdote. I have found it very helpful in cases of recalcitrant lateral epicondylitis. I probably have used it less than 10 times, and each time it has worked really nicely. And I will use it again when a patient tells me that cost is no object. I don't keep a centrifuge in my office. When I do these procedures, I call a company that brings in all the supplies and brings in the centrifuge. My nurse draws up the blood samples, and the sales rep works the centrifuge and retrieves the layer of platelet-rich plasma for me. Surgery is rarely needed for lateral epicondylitis. Sometimes it's needed because too many cortisone injections have been given. These repeated injections can lead to further tissue degeneration. And in fact, when you look at the tissue under the origin of the extensor brevis muscle, you will often see cortisone crystals mixed with the granulation tissue. The key to the procedure is isolating this wrist extensor origin, the ERCB, and then elevating it off the bone. You'll look at the tissue and you'll see it looks hypovascular. Granulation tissue between the muscle and the bone is then removed with a curette. I will then make tiny drill holes into the lateral epicondyle, which promotes bleeding and neovascularization. So the procedure is one that really kickstarts a healing reaction by removing hypovascular tissue and then stimulating a new blood supply for the muscle attachment site. This can be done through a 4-centimeter incision with no need for mobilization, and a rapid return to work and activity is usually within 4 to 6 weeks as the pain settles down, depending upon what kind of work the person does. A less common source of elbow pain is medial epicondylitis, a similar condition affecting the inner aspect of the elbow, the medial aspect of the elbow. This is sometimes referred to as golfer's elbow, and it involves the flexor pronator mass of muscles. The same principles apply for treatment. There is point tenderness over the medial epicondyle, and provocative maneuvers such as forced active wrist flexion and forced active finger flexion and forced active pronation lead to increased pain. Treatment includes activity modification, wrist splinting, and injections. Surgery is rarely needed. Right behind the medial epicondyle is the ulnar nerve. The ulnar nerve provides sensation to the 4th and 5th fingers, and the ulnar nerve innervates many of the intrinsic muscles of the hand. Compression of the ulnar nerve is not uncommon and can produce symptoms similar to medial epicondylitis. Sometimes it looks like carpal tunnel syndrome with point tenderness right over the medial epicondyle. Compression of the ulnar nerve occurs within the cubital tunnel. A pinched ulnar nerve causes pins and needles of the 4th and 5th fingers. Cubital refers to elbow, carpal refers to the wrist. Cubital tunnel syndrome is caused by ulnar nerve compression behind the medial epicondyle. And here is another case of a fibroosseous tunnel that is unyielding to any increase in inflammation and swelling. Patients complain of symptoms that wake them from sleep at night. They wake up with pins and needles of the fingers, which is caused by sleeping with the elbow flexed. They complain of pain that radiates down the ulnar aspect of the forearm, often into the hand. In long-standing cases, there will be atrophy of the first dorsal interosseous muscle, as seen in the picture on the left, and there may be also hypothenar muscle atrophy, as you see on the right side. In severe cases, you may see clawing of the fingers. On examination, there will be a positive Tinel sign as you tap over the ulnar nerve right behind the medial epicondyle. When you tap on the medial epicondyle on the ulnar nerve, this will produce paresthesias if the patient has the condition. These paresthesias run down into the 4th and 5th fingers. If you ask the patient to repetitively flex to extend the elbow for 30 seconds, this will cause pins, needles, and pain. And if the examiner presses on the ulnar nerve, which is just behind the medial epicondyle, and holds the elbow flexed for half a minute, this will often produce pins and needles. Cervical radiculopathy can mimic cubital tunnel syndrome, and an EMG study can clarify things and also provide for an index of severity of the condition. Early on, a nighttime resting elbow brace, like you see here, locked at 45 degrees, can really provide a fair amount of relief by preventing too much flexion while sleeping. Activity modification can help by encouraging the patient to avoid holding the elbow flexed while working. Patients with cubital tunnel syndrome and pins and needles and patients who complain of weakness and pain probably need to have their cubital tunnel released. The cubital tunnel is much longer than the carpal tunnel, and there are multiple anatomic sites that can produce the compression. The nerve compression can occur behind the medial epicondyle. It can occur above it or below it. This picture illustrates compression just distal to the medial epicondyle, where the nerve is abnormally narrowed. That's right underneath the nerve that has the star on it. Below the medial epicondyle, you can see how swollen the nerve is as a consequence of compression distal to that spot. This picture shows the nerve after it's been released. Dissection of the nerve is carried out about 8 centimeters proximal and distal to the medial epicondyle to look for other compression sites. This is something that most of you in primary care medicine see many times, and I've seen many times. Bursitis is inflammation of a bursa. Bursa are found throughout the body around most major joints. The bursa is a fluid-filled sac that is lined with a synovial membrane. The fluid inside the bursa is synovial fluid. It certainly seems like the function of the bursa is to enable soft tissues to glide over bony prominences. The bursa reduces friction between dissimilar moving parts. Here you see a fluid-filled bursa overlying the olecranon. The olecranon is the proximal articulating portion of the ulna. Most of the time, this is not a painful condition, and most of the time, this has an insidious onset. And most of the time, there is no underlying trauma. Some of the time, the onset can be traced back to a prolonged period of leaning the elbow on a hard surface. When there is pain and redness, infection has to be ruled out. This comes down to a simple aspiration using an 18-gauge needle and a 10 cc syringe. Here, I'll just freeze the skin with ethyl chloride and pass the needle about 1.5 centimeters into the bursa. I then send the fluid for gram stain culture and crystals. Sometimes an elbow bursitis is caused by gout or pseudo-gout. Sometimes the septic process is obvious. This bursa is full of pus and needs to be incised and drained. This is usually done in the operating room. For simple Olecranon bursitis, really nothing has to be done. If the elbow bursitis is drained, the fluid tends to come back pretty quickly. The best treatment here is no treatment at all. The problem is that this process can take months to resolve on its own, and I've seen swelling resolve spontaneously in 2 months or 4 months and up to 6 to 7 months. I've found that for cases that show no sign of resolution after 6 to 8 months, it is reasonable to offer a bursectomy. That's an excision of the bursa, which is done with a 4-centimeter incision in the operating room. Moving proximally shoulder pain is a very common complaint seen by the PCP and orthopedic surgeon. These 5 conditions present in an identical manner. I want to start this shoulder discussion with cervical radiculopathy. As I've already said, I call cervical radiculopathy the great imposter. When it comes to differential diagnosis of almost any upper extremity disorder, you must include the diagnosis of cervical radiculopathy. So cervical radiculopathy can look like almost anything in the upper extremity. It can mimic carpal tunnel syndrome. It can mimic cubital tunnel syndrome. It can look just like lateral epicondylitis or thumb carpal metacarpal joint arthritis. Cervical radiculopathy can produce neck pain. It can produce headache pain. It can produce shoulder pain. It can produce chest wall pain. And it certainly can fake out doctors, orthopedic surgeons, and even shoulder surgeons. So when considering shoulder pathology, you must think about cervical spine and cervical spine pathology. I would estimate that in my practice, almost 50% of patients who present with shoulder pain have a cervical radiculopathy. The precise location of the pain is often the clue to the diagnosis. Patients who present with shoulder pain admit to having numbness and tingling, pins and needles, probably have a cervical radiculopathy. And patients who present with shoulder pain and complain of pain that radiates down the arm probably have a radiculopathy. Patients who present with shoulder pain on examination have tenderness over the paracervical and periscapular muscles, most often and most likely have a cervical radiculopathy. Patients come in the office and say that they have shoulder pain that's localized to the upper back and shoulder blade are most likely suffering from a cervical radiculopathy. If a patient comes in with shoulder pain after being involved in a motor vehicle accident, they probably have a cervical radiculopathy. These patients should always be asked to demonstrate their cervical motion. You should ask them to flex and extend their cervical spine, ask them to lateral bend and rotate to the left and right, and they'll often complain of pain that they haven't noticed before. Patients who present with shoulder pain that is caused by cervical radiculopathy will have painful active and passive shoulder motion. These patients often demonstrate pain with some of the provocative shoulder tests that we use that are designed to diagnose things like rotator cuff tears, labral tears, and biceps tendonitis. And some of these patients will end up having pathology in the cervical spine and the shoulder, which makes it extremely perplexing. But the key here is to rule out, if possible, cervical radiculopathy in every patient who presents with shoulder pain. And it's important to remember that you can have a cervical radiculopathy and have no neck pain. That's very difficult for patients to understand. If you make the diagnosis of cervical radiculopathy and there are no asymptomatic reflexes and there's no loss of upper extremity strength and there's no evidence of cervical myelopathy, treatment always starts with physical therapy. So most patients respond very well to physical therapy who have cervical radiculopathy, and it's really through a combination of stretching and strengthening of movement exercises coupled with passive modalities. Pain usually and discomfort usually settles down. For severe acute cases of cervical radiculopathy, I will often recommend a 10-day course of methylprednisolone. And this will start with a 4-day course of either 24 or 32 milligrams of methylprednisolone, followed by a medral dose pack. I have found that the medral dose pack alone just doesn't do it. If in 6 weeks' time things don't improve, I will recommend an MRI study. And as long as there is no severe disc herniation or nerve compression or cord compression on the MRI study, I will then send the patient to pain management for a series of cervical epidural injections. This is an MRI that shows severe spinal cord compression at several levels. If you look closely, you'll see high signal within the cord, which is indicative of myelomalacia. Myelomalacia is a pathologic softening of the cord. It's usually caused by compression. It can have devastating consequences. Compression of the spinal cord leads to cervical myelopathy. Cervical myelopathy leads to a loss of muscle function, a loss of sensation, and a loss of autonomic function. Ataxia is commonly seen in older patients with cord compression. Loss of bladder or bowel control is often part of the picture, but not everybody with myelomalacia has a cervical myelopathy, and not everyone who has an MRI study that looks like this needs surgery. This image that you see, this MRI image, can be consistent with a process that has been progressing slowly over many years and is being tolerated by the patient with few symptoms. It's unlikely, but this is possible. Much more common than cord compression is nerve root compression. Nerve root compression is usually caused by a disc herniation or a hypertrophic facet joint. The picture on the right is an axial view of the C6, C7 disc space. The arrow points to a large eccentric right-sided disc herniation that's causing severe compression of the right C7 nerve root. Remember that it's reversed, left is right and right is left on all of our images. Most likely this will not respond to conservative measures, and most likely this is associated with significant symptoms and dysfunction. This problem is best treated with a cervical discectomy and fusion. Getting back to the shoulder, once cervical radiculopathy has been ruled out, the most common cause of shoulder pain is shoulder impingement. Impingement syndrome involves the shoulder bursa, the rotator cuff, and the acromion, which is part of the scapula. With elevation of the arm, the bursa and the rotator cuff get pinched by the acromion, as you can see in the figure on the right. This is a process that occurs outside of the joint space. It occurs in the subacromial space. And it's believed that this constant irritation causes a shoulder bursitis, and an MRI study at this point would show increased fluid within the bursa. This condition is thought to come about as a consequence of rotator cuff weakness. As you recall, the rotator cuff is made of 4 muscles that take origin from the body of the scapula. The supraspinatus tendon lies directly under the acromion and under the bursa, and it is the rotator cuff muscle that is the object of impingement. It's called the supraspinatus because it lives above the spine of the scapula, as the picture shows. The portion of the supraspinatus that is involved in impingement syndrome is the tendinous portion, the end of the muscle. The tendinous portion inserts into the proximal humerus adjacent to the cartilage. This attachment site is called the greater tuberosity, and it is here that the rotator cuff tears away from the bone. Typically, patients with impingement syndrome will point to the lateral aspect of the arm and the region of the deltoid muscle as the site of their most significant discomfort. They'll walk into your office with their hand over their upper arm just like this, and they'll tell you that they have more pain at night, especially when they're in bed, and they have difficulty sleeping on that side. Patients will tell you that they have difficulty reaching their hands behind their upper back or behind their lower back. They complain of pain with overhead activity. They'll tell you that they have difficulty reaching for their seatbelt. A good physical examination test which points to pain coming from the subacromial space is forced passive interrotation and external with the elbow flexed in both the coronal and sagittal planes. These 3 pictures are actually all the same picture, but in each picture, the image on the left demonstrates motion in the sagittal plane, and the image on the right demonstrates motion in the coronal plane. With these motions, the examiner is rotating the humeral head and moving the rotator cuff and the bursa underneath the acromion, and this causes pain when impingement is the problem. Early on, it's reasonable and beneficial to inject the subacromial space with cortisone. For many patients who do not have severe impingement, this may resolve the problem, and most patients do not have severe impingement. For most patients, you see with shoulder pain, the impingement is usually mild and produces a bursitis. So the subacromial injection gets the medication into the bursa, and it's a rather simple injection with the landmark being the posterior prominence of the acromion, as noted by the arrow. 2 centimeters below that prominence is a soft spot that is the entry point to the subacromial space. Because of the shape and the orientation of the acromion, you want to come in at a 30-degree angle so that the needle hits the top of the acromion. This way you'll know you're in the right space. So this is what you're aiming for. This needle is placed parallel to the undersurface of the acromion in the so-called subacromial space. Below the needle is the rotator cuff that is part of the soft tissue envelope around the shoulder joint. The subacromial space is separate from the joint space. I use 9 cc's lidocaine with 1 cc of cortisone. Once I know I'm in the space, I will usually inject half of that mixture into the space. Again, this is called the subacromial space as it is inferior to the acromion, and it's not part of the articular joint space. This is the space where the bursa lives and where the rotator cuff lives. So if the injection works, I stop here. If the pain persists, I go right to physical therapy. The goal of therapy is to strengthen and condition the rotator cuff muscles and the so-called scapular stabilizers. This is done with a combination of free weights, elastic bands, isometric and active resistive exercises. Passive capsular stretching is also helpful. This passive stretching is done by the therapist. The patient is instructed on a home exercise program. When simple measures fail, an MRI study is recommended. The presentation of impingement syndrome and shoulder bursitis is often identical to the presentation of a rotator cuff tear. Understand that most rotator cuff tears are seen in patients over 40 years of age, and with each passing decade, the incidence of rotator cuff tears increase. It is not a condition of younger individuals. Rotator cuff tears do not occur in younger individuals. And what's important to understand is that an MRI study that shows a rotator cuff tear like this doesn't necessarily define the etiology of one's pain. Like many other orthopedic conditions, there are many asymptomatic joints and asymptomatic soft tissue structures that have pathology on imaging. Asymptomatic with pathology on imaging, we see this all the time in orthopedics. Whether it's a meniscal tear or an arthritic knee or a rotator cuff tear, abnormal imaging can be associated with no pain and no symptoms. The imaging must support presumptive diagnosis to make the final diagnosis. And in fact, ultrasound studies in asymptomatic older patients demonstrate a very high rate of rotator cuff tears. So there are many people walking around out there with rotator cuff tears who don't know it because they have no symptoms. Rotator cuff tears usually involve the supraspinatus tendon, as shown here. The tendon tears away from its attachment to bone. The problem is mostly attritional. It's a wear and tear process that's linked to relative avascularity at the attachment site. It's thought to be related to mechanical forces of impingement, where repeated microtrauma from impingement leads to loss of tissue integrity. With rotator cuff tears in the elderly and the less active, non-operative treatment is reasonable. With age, the substance and the integrity of the rotator cuff tissue lessens, and rotator cuff repair results are much less predictable in older patients. But for the majority of active patients, those under 70 years of age, repairing the rotator cuff is recommended. Rotator cuff tears are repaired arthroscopically through a series of puncture holes about the shoulder anchors with sutures attached or driven into bone. And the sutures that are then used to secure the tendon back to bone. The red arrow in this picture shows a cutaway view of the anchor in the bone. We usually use 4 anchors to secure the repair. Recovery tends to be slow, up to 6 months, with a need for extended physical therapy. For the elderly who have persistent pain and do not respond to physical therapy, surgery can be considered. But as I noted, with age, tears get much bigger, and the poor tendon quality can make it impossible to get a good repair. Sutures just tear right out of the rotator cuff. They can't secure the rotator cuff. In some cases, and not infrequently, long-standing rotator cuff tears in the elderly can lead to what's called a rotator cuff arthropathy. These x-rays show what a long-standing rotator cuff tear can lead to. The image on the left shows what is referred to as a high-riding humeral head. Here there is no rotator cuff remaining to keep the humeral head in place, and the humeral head migrates superiorly into a chronically abnormal position. When a joint is chronically malaligned or subluxed, and when the joint fluid can no longer remain in a closed space to provide nutrition to the cartilage, arthritis rushes in. The term rotator cuff arthropathy refers to the resulting arthritis that occurs as a consequence of long-standing rotator cuff tears. The image on the right shows a suture anchor that was placed too late in the cuff tear process, and the repair failed, which led to this high-riding humeral head. An ingenious solution has been widely used for the past decade. The reverse shoulder prosthesis reverses the position of the ball and the socket. So where the humeral head once was, there's now a socket, and where the socket once was, now there is a ball. This is done to change the biomechanics of the shoulder. This is done to dramatically increase the efficiency of the deltoid muscle. What the ball that is now sitting on the end of the scapula does is it lateralizes the center of rotation of the joint, giving the deltoid a mechanical advantage to function. What the rotator cuff does in the normal shoulder is it keeps the ball in the socket. With the ball in the socket, the deltoid works well to abduct and forward flex the shoulder. When the rotator cuff is damaged, the ball has nothing to keep it inside the socket, and deltoid contractions just pull straight up on the humerus, and the humerus moves superiorly, just like you see with the high-riding humeral head. Without the rotator cuff to stabilize the ball in the socket, when the deltoid contracts, it does not produce a rotation, it produces a translation, and the humeral head just moves up to the acromion as demonstrated by the red arrow. With the reverse shoulder replacement procedure, the center of rotation where you see the blue star is moved out laterally. In this case, it's moved out to the left, giving the deltoid a mechanical advantage. And this goes to the presentation of rotator cuff tears. Often, especially after an injury, a patient will present to your office with a dead arm. There's no active abduction of the shoulder. The patient has to lift up their arm with their other hand. They can barely get to 30 degrees. They have to move their whole body to get their arm this far. This is because the rotator cuff can no longer keep the humeral head in the socket. And when the deltoid contracts, it's unable to produce rotation and only produces superior translation. We're running out of time here. I'm almost done. A few more slides. This is the other type of shoulder arthritis. This is osteoarthritis that is not related to a rotator cuff tear. This is the wearing away of cartilage with the ball still uniformly located in the socket. You see sclerosis of the bone edges. You see cyst formation and narrowing of the joint space, just like in any other joint arthritis. The presentation here is a little different in that most patients who have shoulder arthritis, which is osteoarthritis, point to the anterior aspect of the shoulder and not to the deltoid as the site of the most significant discomfort. And these patients are usually able to fully abduct their shoulders. Passively, there is marked limitation of glenohumeral joint motion. The way to examine for this is to stabilize the scapula with one hand and abduct and externally rotate the flex form with the other. These two passive motions where the examiner moves the arm will be limited and reduced. This severe loss of passive motion is not commonly seen in rotator cuff generated arthritis. Treatment of glenohumeral joint arthritis starts with physical therapy with exercises similar to those used for rotator cuff impingement. Anti-inflammatory medications can be helpful. The injection technique for a shoulder joint is a little different from the injection technique for the subacromial space. You still use the same starting point under the posterior corner of the acromion, but here you don't aim up, you aim towards the coracoid. Your needle is parallel to the floor, and you use your finger on the coracoid process, and you aim for your finger on the coracoid process to get inside the joint. The coracoid process is a appendage of the scapula, and for shoulder surgery, the coracoid is the gateway to the shoulder. All surgery is always done lateral to the coracoid, and you can feel the coracoid under the skin. This injection is a bit more difficult than the subacromial injection, and for that reason, it's reasonable to use ultrasound to make sure you're in the joint. And finally, when all else fails and simple measures do not help and the patient is limited by daily activities, surgery is the answer. Surgery is the answer when the patient is in good or optimized medical or physiologic condition. This is the more traditional approach to surgery, to shoulder replacement surgery, where the ball and the socket are placed anatomically. The worn out cartilage surfaces are removed and replaced with cobalt chromium or titanium and high density polyethylene. And with that, I'm going to stop. That was a long talk. We've covered a lot. You must have a lot of questions, and obviously there's no time to answer questions, so you can reach me, cell phone, my office phone, email, whatever. Thanks for your attention.
Great. Thank you, doctor, and thank you for that great informative presentation. We really appreciate your time today. And this presentation has been recorded. It will be posted on our YouTube channel, the Trinity Health YouTube channel. If anyone needs that link, please let me, Kathy Price, or Nicole Yeager know, and we'd be happy to provide that to you. Thank you, everyone, for attending, and thank you, doctor. Appreciate it.
Thank you, Kathy.
Bye-bye.